Thank you, Dr. Sharma, Jyotirindra Sharma, and happy birthday to you. And I think what an honor to be here together, and also I think it's such an act of compassion together at the time of your birthday. I think it's just not a coincidence, I guess. And without much of delay, I would like to get into the topic. And this event is organized, first of all, to hear from our learned scientist, philosopher, and spiritual mentor, and once upon a time, not even today, characterized as the happiest man on earth. Probably many of you have heard about Matthew Ricard. And we would love to kind of feel that way. And as much as I interact with Matthew, I get that sense and vibe every time I meet him. And it's such an honor to get to know you and be together on this, another act of compassion that you try to teach all of us. It's truly an honor to have Felicity, Excellency Felicity Book, together in this journey. Always, every time we invite you, you be there to support and help us. And there are so many good hearts, great hearts here. And actually everybody who came here has that touch, and that's why you're all here. And this event is also organized to say thank you to each of you who have made a difference already in thousands and thousands of lives of children. And I'll briefly share with you what has happened and what contribution have you all made already. I think that's another reason that we wanted to share, and also to just share with all of you what physical progress has happened and what we dream to do in future. And of course, it's good to get connected and share between all of us the ideas, the progress, the challenges, the pain that we have. Again, thank you, each of you, for being with us today. I think it's not new that we have been working on it as a small team, as Jyotirindra said, since 2017. We thought that a lot of things have happened in Nepal for children's health, and the death rate of under 5 children, under 1 year of age children, and neonates has significantly declined. But over the last decade or so, 10-15 years, the death is stagnant and has not come down anymore. So we all think, and with our scientists like Professor Adhikari and many others, we truly believe that unless we change the way we take care of kids, this is not going to change. Prevention is great and needs to be done and built upon, but the country has to move on to treat if and when children get sick. And that's where the problem is. And we truly believe that this needs to change if we really want to help our children. So we phrase this, we dream about complete model of children's health care, which is fostering the present, the level of care, and ensuring the future of our children. Nepal has done a lot of work in the communicable diseases side, and the burden of communicable diseases, maternal deaths and infections, diarrheal diseases and others have significantly dropped over a period of time. But at the same time, alarmingly, the burden of non-communicable diseases among adults as well as among children has been sharply rising. And Nepal is part of signatories of the international community, where we signed a commitment to achieve the Sustainable Development Goals by 2030 and to reduce the childhood mortality, among many others, by 2030. And there is a very important reason to talk about this, because child health has the highest impact on an indicator that we use in public health on disease-adjusted life years. People may leave, but they are sick, they cannot work, there's a lot of economic burden. This has the highest impact on those what we call tallies and the years of life lost. If you die prematurely, then let's say if somebody dies at the age of 30, the expected survival would be 70 to 80, then 40 years of life is lost already. So from those two major public health indicators, the child health has the highest value. And from that perspective, from health economics perspective, I'm also learning that as we grow and do the project, is the highest return on investment. Health has about 6 rupees return on 1 rupee of investment. That's the usual calculation on health economics. But if you put the same money in children's health, the return would be much higher, maybe double, maybe triple of what happens in adults. So there's a global north standards. The children die, only 3 out of 1,000 die before the age of 5 in the most developed countries. Here we have 33, 40 children dying. And Nepal's situation I'll show you in a bit. So this is the concept that we took. It's a kind of big challenge for a non-profit like us, but it's something necessary. This is the founding board that we will call SENSI. That's the concept that we took. The current board of 7 people, we're here, pretty much everybody's here. And I thank everyone and each of you for bringing the concept up and taking this forward today. So thank you all for being together on this. Now, this is the scenario. Why are we bothered about this? This is unacceptable. This death rate of children. I'll say something in Nepali. In villages, the mothers sometimes don't even say, my kid died. They get 4 children and 1 or 2 die. They say, Kerala. Kind of wasted. And that's not normal for a civilized society because they tend to accept high death rates in villages. That's not normal. And so there's a lot of problem in nutrition. There's a lot of problem in hemoglobin and other healthcare indicators. Many of these deaths can be easily avoided with appropriate care, which are time of way. There's still a lot of disparity in the gender, based on gender. A lot of kids, girls die. And then actually, I'll show you some of the slides from Damak. Damak, I have 40,000 some children we've already treated, and I can share you that. The attendance in hospital is far higher among girls than boys. So there is, reverse. The boys' attendance is higher than girls. There's a problem there. So is this gender biases or there is some sort of a disease pattern? But we need to look into this. But there is a very differential, in fact, discriminatory attendance in the hospital. There are 4,000 plus institutions in the country, but there is only 1 dedicated children's hospital in the country. There are many other departments and smaller private hospitals, but in public sector there seems to be 1. And clearly for over 10 million children, 1 or 2 few hospitals for children is not enough. So I think this is why it's important to build on the current efforts of immunization, WASH program, community-based treatment of infectious disease. But also now I think Professor Adhikari will also add on to this point, and a lot of international academic centers and institutions focus on is to strengthen and decentralize the secondary care for children, remote site and develop multidisciplinary specialized children's hospital in the centers or in the central parts. Then only we would be able to take care of most of the problem. The concept, you know it, we want to do this. Looks a little ambitious, but we're getting there step by step. And it's not just hospital thing that we're looking at. We also want to contribute or help the society by doing some research, helping in public health sector, which already started, and community outreach programs. And then I think we could say the comprehensive institutional model that not just treatment, but also doing research, also doing public health. So this is the timeline. I think this is a little busy slide. And kind of very hard to meet the deadlines because your objectives are subject to so many factors, including the funding situation and the national situation, political changes. Third, what we envision is Kathmandu project we should be able to complete in next 2 to 2.5 years. It's already started. The Koshi Provincial Hospital is ready and running for 9 months now. I'll show you how that's happening. And remaining provinces will go once the Kathmandu is secure, depending upon how the provincial governments will respond. And interestingly, there is so much of demand on the provincial government side that they want development to be seen, they want to work with the good partners. And there's a lot of interest coming in, but we're hesitant because unless we secure our platform in Kathmandu as a resource center, it will be challenging to run another site. So we're focusing on Kathmandu now. But we think this concept is viable and doable if we all come together, particularly if you all help, and you're already part of this. So, and then after that we'll have phase 3 for remaining several provinces. Kathmandu is, glimpse of Kathmandu project is this. It's very challenging in terms of terrain and all, but foundation work is done. One clinical research building is up and people are already working. We do public health. District hospital project is running from this building. We work together with the Harvard group and the UNICEF supports some, not huge funding. Also together with the district hospitals of the government of Nepal. So it's one concept that we took is already up and running. As a proof of concept, our phase 2 Hunupanich is something that was supposed to be phase 2 decentralizing became phase 1A because there was a need and request and available resources given to us from Koshi province, Jhapa, Dhamma. And this is something that we've already launched. So I think we went a little ahead of time here. And now this is 50-bedded children's hospital in Damak. We had to retrofit, add 2 floors on 2 sides and complete this project. It's up and running for 9 months now. And KIOCH services is already there now. And we have almost like 150 staff working there in that hospital in this span of 2.5 years. We built it, equipped it with the generous support from probably each of you. In some way or other, all of you were involved in getting this done. And this is a great opportunity for us to say thank you to all of you. And these are major services, neonatal care, intensive care, and I'll list out who all contributed. Examples of this is on the left is emergency room, pretty crowded now already. There's a lot of children come. Outpatient services. And this is neonatal intensive care on the left. High dependency unit on the right. Pretty state-of-the-art equipment, technology, and beds. And we'll just look at this. This is 1 month old data. We already saw 32,000 children by end of Paus. In last 2 months, we probably saw another 9,000 children already. So I think the number has crossed 40,000 children by now. 6,000 emergency attendants 2 months before, and some 44,000 labs, echocardiography, ultrasound, and others. This is some important thing I really want you guys to see and assimilate. Somebody said some time ago that this project is not viable because this is fundraising based, Yes, it is. It's not private equity. It's not a private project. It's a non-profit. We all are social workers. We work pro bono, free. Of course, the staff will be paid. But look at that. With the fees that put in lower than the government rates, and the national government insurance rate, end of March, we're meeting the expense with the operations, the general internal revenues. There is a lot of caveat within this. It's not that simple, but the expense is in golden and the revenues are in blue. And we're almost meeting that. At least for the point in time with MAD, we were meeting the expense with the revenues. And there is a gap. There is a gap. Thank you. And there is a gap in between. So we're still having dues to pay from the equipment and technology. But in terms of operations, I mean, we knew this from last number of institutions that we built and ran in many different ways. With some external support, the government or foundations or something, I think these projects, if run well, without leakage, without any irregularities, I think these are sustainable, should be sustainable, particularly with the agreement with the provincial government. There is a rate revision to insurance rates and adding new services. So I think it is a proud moment for us to tell that, look, I think KIOCH provincial model gives us confidence that it can be made sustainable. And what an opportunity to thank you all. It's a very busy slide because there are so many donors that helped us. And the KIOCH provincial government being number one, and Warmness Foundation was big time, God-gifted donation without expecting anything. This Warmness Foundation guy said, oh, we will support you the 6 months operating cost. We had no idea how we run in the first year, but then just came in. The Unica Foundation, by the way, the Australian Embassy, the Punyasri Foundation, you can name it, all of that is there. But and then many donors who donated in kind, equipment, whatever they had, rather than cash. And we love to get donation in kind rather than getting money and trying to buy equipment. We're at least interested in the procurement, but you got to run it. So we thank each of you. Many of you are present here. If not, we'll send it to them. And this is how the one project was made possible. And idea is to have KIOCH government partnership. It's officially agreed upon. We have an agreement with the government. So we want to work at the lowest level of government institutions to train them, help them, make a referral pattern. Provincial hospitals also will probably work with our provincial institutions in long run. And KIOCH Kathmandu Central Hospital will probably work together with Kanti. We're very open and trying to make an agreement with the government. At the central level, we have an agreement with the Ministry of Health to help develop the pediatric care, and also government will impanel the services as part of the government services. So that model should work. Of course, it's not harder than what we think and imagine it easy to do. Well, I mean, I'm not a public health expert, so this is done by me, so forgive me for your errors. But the idea is we will touch millions of children's lives in the next 10 years. And if you just calculate how many children we've seen in Damak now with the 50 beds, if we have 7 hospitals, in 5 years, in 1 year we'll probably see more than 500,000 children every year. Of course, many of them will come back, it's not new, but probably more than 1 million new lives touched in the next 10 years. So I think that would definitely make an impact if we train other government public institutions and then help them improve the quality of care. And as I said before, there is a direct economic impact. Through insurance, children's lives will be saved, their morbidity, illnesses will be saved. And the one thing that we always like to argue, and this is something that it is also an agenda of national security. It's not just the health and economics, because the children will be committed to the society because society gave them a chance, second chance. And I see my colleagues, Jyotindra and I worked with thousands of children in heart. We operated, maybe 5,000-6,000 children, and we see them are a different lot of people committed to children. And I don't need to say this, but I think why an institution like KIOCH, as I said before, there's a rising need. Children are the present and future. And by the way, as Nelson Mandela said, a society's soul is reflected in the way the society takes care of the children. If society takes care of children, then that society is civilized and is kind. I think it is an indicator of society's heart and soul. And of course, we have a committed team of founders and the current board, which is completely pro bono. And why this type of issue? Why not government? There's always a question. Why not government? Government should do this. Why should you be smart enough to talk about it? And we're trying to help government. It's not contradicting the government. It's not business. It's not competition. But it's the right model of partnership. Sarkari hospital problems. So there are issues in governance, sustainability, Darbandi. Government has huge challenge in adding the human resource for its own public institution now. So adding 2,000 additional Darbandi in the government system for children would be impossible for at least next 10 years. So that means that I think that something like this would ease that kind of deadlock out. That's our argument. And decentralization, professional management, and centralized quality control through a team of management, I think is the right thing to do. And many other institutions, not profit like us, like Dhulikhel, name it, Tilganga, name it, the Netra Jyoti Sangh, Bayanpada model, all of these have proven that if you have a right team of managers and group, I think they will work better. So I think this is a good model to have, at least we argue, and it's a complete solution for children. So hopefully that will happen. And end of the day, the law states that if something goes wrong with the institution, hopefully not, then it's all government property. It all converts into a government asset. So you cannot go wrong. We can go wrong, but the institution cannot. The expectation, nothing really. We just wanted to share with you all, what we think and how we want to move. How kind act of compassion is this to help children with no conditions put forth. No conditions. It's not just funds. It is funds for sure, but technology, equipment, training, fellowship, helping capacity building, and just patronizing, supporting, word of mouth, and we also build the referral linkages. So I think this is what we expect from all of you, and through your networks. And finally, all these children who have been benefited, we try to come up with this trademark, the phrase, let them dream, let the kids dream. If they get better, they're healthy, then they can dream of their future, and who knows who they become in future. And that's something that we would like to be part of. So with this, thank you very much for being with us, attending, and I'll stop here.